Good evening all. Welcome to the 11th webinar of the Maha Smiles Cleft Care for Every Child. I would like you all to introduce to Miss Renu Mehta. She is the Area Director of Smile Train India. So over to you, Renu.
Thank you, Rohan. Good evening, everyone, and a warm welcome to you all. Uh, you may know or may not know, so I'm going to just give you a brief on what Smile Train is. So Smile Train is world's largest cleft-focused NGO. We support safe and quality cleft care for children globally, and we enable them with the opportunity to live full and healthy lives. In India, we work through a network of partner hospitals. Currently, we have 127 across the country. And over 2 decades now of us working in India, we have supported more than 740,000 cleft surgeries to these partner hospitals. And we have been in collaboration with Foxy since 2019, and we are extremely grateful for this partnership. Today, I will be sharing a new initiative that Smile Train has started, which is focused in Maharashtra. This is called Maha Smiles, Cleft Care for Every Child. Now, this Maha Smiles is a CSR collaboration between Bajaj Finserv and Smile Train India. And under this collaboration, we aim to build awareness and support treatment for children, specifically in the state of Maharashtra. The plan is to sponsor or support 8,000 life-transforming life surgeries through this program within a period of 36 months, that is 3 years. And we also will be creating awareness about the importance of the timely treatment and timelines of cleft treatment. In Maharashtra, we have 11 partner hospitals across 10 cities that we are supporting. In case you come across any child who is born with cleft, my request is to please refer these children and parents to the nearest Smile Train center in Maharashtra. We also have a toll-free cleft helpline. You may call on the cleft helpline, which is 1-800-103-8301. You can share this number with the patients and their families, or you can tell them to reach us at www.smiletrainindia.org. So it's my privilege to introduce Dr. Rashmi today. Dr. Rashmi Kahar is here. Is she here, Rohan, or Dr. Sujit, are you going to take over?
Sujit sir will take over.
Okay, Dr. Sujit, so over to you to take the webinar forward. Thank you once again.
Thank you, ma'am, for your introductory words. Good evening, respected seniors, dear friends and colleagues. We are going to present 11th ECME about cleft lip and cleft palate. This series has been started by AMOX in collaboration with Smile Train India to increase awareness about cleft lip and cleft palate. We are very much thankful to our past president, respected Dr. Rajan Singh Pardeshi sir, President Dr. Kiran Kurtikar sir, Secretary Dr. Bipin Pandit sir, and the entire office bearers of AMOX for constant support. We have two eminent speakers today, Dr. P.V. Narayanan sir, who is going to talk on management of cleft lip and cleft palate, and Dr. Ashish Jhararia, who is going to talk on overview of cleft lip and cleft palate. I welcome and invite you as we are eager to listen to you. Without any delay, I would like to introduce our guest of honor, Dr. Pardesh sir, today, because chief guest Dr. Kiran sir is not available today. So have Pardesh sir joined today? Yeah, sir, good evening. Welcome, sir.
Sujit. Good evening.
Yeah, Dr. Rajan Singh Pardeshi is having the main role in starting this series. He is actually pioneer of this whole thing, which we have been doing since last so many months about cleft lip and cleft palate. Over to you, sir, requesting you for your some golden words of guidance.
Good evening, everybody. Respected chief guest, Dr. Kiran Kurtakote, sir. Guest of honor, Dr. Bipin Pandit. Conveners, Dr. Sujit Kondkar, Dr. Rashmi Kahar, Dr. Jaya Tulaskar. So, I wish to express my sincere thanks to Smile Train for this social initiative. I call this social initiative. It's really a divine program. I wish to congratulate again to Dr. Sujit Kondkar, Dr. Rashmi Kahar, Dr. Jaya Kore for organizing this webinar. And with the speakers like Dr. P.V. Narayanan and Dr. Ashish Jararia, I think this is going to be a great event. I wish to express again thanks to Rohan and Dr. Renu for supporting this event actively. I wish every success to Dr. Sujit Kondkar for his future endeavor in Foxy, as he is contesting for the post of chairperson of Imaging Science Committee, as well as I wish every success to Dr. Rashmi Kar for her future endeavor in Foxy, as she is contesting for the post of chairperson of Practical Obstetric Committee. So I don't want to be in between you and scientific content. Wishing again every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir, for your words of guidance. Without any further delay, we are going to your first talk. I would like to invite and welcome our esteemed speaker today, Dr. P.V. Narayanan, sir. He is head of department of the Charles Pinto Center at the H.S. Adenawala Institute of Cleft Lip and Cleft Palate, Jubilee Mission Medical College and Research Institute, Thrissur, Kerala. He has been project director, Smile Train and member, Smile Train Indian Medical Advisory Council. Respected sir started his career in general surgery at Jimmer, Pondicherry, and subsequently worked at Apollo Hospitals, Chennai. After his FRCS, he trained in plastic surgery at Royal Preston Hospital, Preston, UK. He returned to India in 1998 and joined the Charles Pinto Center for Cleft Lip and Palate, Jubilee Mission Medical College and Research Institute, Thrissur, under Dr. H.S. Adenawala. He has been Smile Train accredited surgeon since 2000. Since 2007, Dr. Narayan sir has been solely dedicated to cleft care. He has a passion for the correction of cleft lip nose deformity. Respected sir is a life member of Association of Plastic Surgeons of India and the Indian Society of Cleft Lip, Palate and Craniofacial Anomalies. He is also a member of Smile Train Indian Medical Advisory Council since 2020. Respected sir has awarded PGIMR IT Jackson Cleft and Craniofacial Surgery Award 2021. Respected sir, requesting you to deliver your talk. Everyone is eagerly waiting for you.
Thank you very much, Dr. Sujit, for the very kind words. And I thank Smile Train and Foxy and the Maharashtra Gynecological and Obstetric Societies for this initiative, which I think is very, very important to get the two groups together for the better care of cleft lip and palate children everywhere. I'm going to start sharing my presentation. Is it seen there?
Yes, sir.
Yes, sir.
Please make it full screen, sir.
Okay. So the talk will be on the management of cleft lip and palate child. This actually extends from birth till at least around 18 to 20 years. And short introduction about Smile Train. Renu has already mentioned the aim of Smile Train is changing the world one smile at a time. And give a man a fish and you feed him for a day, teach him to fish and you feed him for life. That is the motto and the model that Smile Train works on, and it has been very successful. It is over the last 25 years, they have helped in the management of 1.5 million children, and at least 7 lakh cleft surgeries have been supported in India by Smile Train. There are 127 partners, as Renu just mentioned. And Smile Train also supports cleft care in more than 90 countries. Dr. Adenawala, my mentor, was one of the pioneers of cleft surgery in India, and he was instrumental in developing our hospital, which was just almost a medical dispensary in 1959 when he started here. And today it is a multi-speciality hospital, medical college, and of course a very proud Smile Train partner. And his passion for cleft lip and palate was from his mentor, Dr. Charles Pinto, after whom he named our center. And for the last 40 years of his life, he concentrated solely on the treatment of cleft lip and palate children. When you take the journey of a cleft lip and palate child, it's with the cleft surgeons and the cleft team, it's from soon after birth until at least around 20 years. Soon after birth, the first counseling happens. I'll just go through this quickly and then explain everything in detail in the coming slides. Around 1 month, we call them back. During this period, already if patients who require nasoalveolar molding pre-surgically will also be sent to them after the first visit. Counseling will be done to the parents about the entire events that are to follow from the birth till around 18-20 years. The lip repair is done around 3 to 6 months of age. This is because of safety reasons that we don't do neonatal repair generally these days. 9 months to 1 year, palate repair. Repair too early may cause more growth problems to the maxilla. Repair too late may cause less than optimal speech results. Then following that, there is yearly follow-up and speech assessment. Around 5.5 to 6 years, we do offer preschool rhinoplasty, as we shall describe later. Around 9 years, alveolar bone graft. At around 6 years or after, surgery for speech in the form of velopharyngeal incompetence surgery when needed. After 11 years, proper orthodontics, and 10 to 14 years, anterior maxillary distraction if necessary, and where necessary, orthognathic surgery in the form of Lefort 1 osteotomy with or without mandibular surgery, 16 to 18 years, and secondary rhinoplasty is done after the bony platform is all done and in order. Antenatal diagnosis these days is very important because in most of the scans that are done to identify the congenital anomalies, the cleft lip is picked up. When there is a cleft lip, that is picked up very more usually. If there is no cleft lip and only a cleft palate, then this may be missed because the ultrasound probe requires a window to focus on the palate. When the mouth is closed, it may not be able to do so in an intact cleft lip, but only when the mouth is open, they may be able to pick up the cleft palate. That's why a cleft palate may be missed. Around 6 to 8 weeks from the conception, the entire development of the face is complete. This has a bearing on what follows now. Many of our parents ask us, why did our child get a cleft lip? Nobody in the family has had a cleft. Environmental teratogens have been implicated. Phenytoin is an anti-epileptic, and if the mother is taking phenytoin for convulsions during those initial weeks after conception, then there can be clefting in the child. Maternal smoking, alcohol consumption are also important. Retinoic acid deficiency, vitamin A analogs are given for severe acne problems, and if the mother is consuming this during those first 6 to 8 weeks of pregnancy, there is a high chance of clefting. Folic acid deficiency has been implicated as a cause of clefting, not definitely proven. However, all obstetricians, I'm sure, do prescribe folic acid once the pregnant mother comes to them. That is, after they suspect pregnancy, they might test for it, and then they come to the obstetrician. This itself might be too late because, as I mentioned, first 6 to 8 weeks, the entire development of the face is complete. So when mothers come to us and ask about subsequent pregnancies, we advise them to take folic acid throughout the period they are trying for a pregnancy. Genetic causes are more important in isolated cleft palates for some reason, whereas when patients have only cleft lip with or without cleft palate, then there is less often an association with genetic underlying cause. Syndromic patients are less in such a group. Some syndromes have been associated with cleft lip or palate or both. Van der Wood syndrome is an autosomal dominantly inherited syndrome where there are mucus pits on the lower lip. Pierre-Robin sequence is something which is not infrequent. We see it quite often. There is retrognathia, micrognathia. The tongue is pushed backwards, and as a result, there may be obstruction to the breathing. And this, when it happens early in life, can be quite severe and quite causing a lot of respiratory distress for the patient, and it might require significant intervention. Milder forms are corrected by positioning. You could place the child laterally, nurse the child laterally, tongue goes to one side, so the obstruction is overcome. If that is also not all right, then prone position may be tried. But in a very small child where head holding has not happened yet, then prone position can be dangerous, then can be smothering. Somebody needs to look after be with the child all the time. If this is not enough, then nasopharyngeal airways have helped in slightly more severe cases, and this bypasses the obstruction from the tongue. If that is also not adequate, then surgical intervention may be needed in the form of tongue lip adhesions. Rare case is tracheostomy. These days, distraction of the mandible is also performed. Chromosome 22 microdeletions is a cause of velocardiofacial syndrome. Velo means soft palate, heart, cardio, and facial. There is a particular dysmorphic facies in these children. The importance is these patients have a poor prognosis for speech. Again, parents come and ask us, we have one cleft child, none of us have a cleft. What are the chances of a cleft recurring in subsequent pregnancies? If only one sibling is affected, then the chances are very less. But if two siblings are affected, slightly more, but significantly increases, the risk increases if one sibling and one parent have a cleft. For a working understanding, a classification of clefts, this Y-shaped diagram helps us. At the center is the incisive foramen. Anything anterior to this is the primary palate. Anything posterior to this is the secondary palate. If only the lip is cleft and the alveolus is intact, it's a partial unilateral cleft lip. If both the lip and the palate are cleft on one side, it's a unilateral complete cleft. If it happens on both sides, then it's a bilateral complete cleft. If only the soft palate is cleft, then it's a partial cleft of the secondary palate. And if the soft and hard palate are cleft, then it is a complete cleft of the secondary palate. Now, there are two other more minor degrees. One is a microform cleft lip, and the other is a submucous cleft palate. The submucous cleft palate is particularly important because it might be missed soon after delivery, when the child is still with the obstetricians and the pediatricians do their first assessment. A detailed look has to be done to see whether there is a submucous cleft. The submucous cleft can be identified by a bifid uvula, a blue line in the middle of the soft palate, and when you feel the hard palate, end of the hard palate, there may be a notch. These are the triad of signs for identifying a submucous cleft palate. Most of them require no further intervention, but some of them may have poor speech, which is just like any other cleft palate child, and those require treatment. A microform cleft lip I mentioned, it's a very trivial form of cleft, but at the same time might be a challenge in the treatment. You have a discontinuity in the white roll. There's a notch on the vermilion, and there may be a nasal deformity as well. This is a partial unilateral cleft lip, a complete unilateral cleft lip, a partial bilateral cleft lip, complete bilateral cleft lip. Significantly, you can see the premaxilla, which is protruded. The soft tissue on top of that is the prolabium. It lacks muscle, and you can see not only is the premaxilla protruded, it's also rotated. This can be quite a challenge. Rarer clefts, lateral clefts may go all the way to the ear. Midline clefts of the upper lip, significant when they are complete. They may be involved, they may be associated with intracranial anomalies like holoprosoencephaly, which may not be compatible with a long lifespan. Now, the oroocular clefts go from the lip all the way to the eye. The nose will also be involved in many of these. During the first clinical visit, that is in the neonatal period, we assess the child. The pediatrician will assess the child. We look for any other syndromes. We look for breathing and nutrition, and the orthodontic consultation is done when necessary for pre-surgical orthodontics. The feeding, we ask the parents to hold the child in a 45-degree inclination so that there can be less chances of aspiration. The cleft lip, the children with only cleft lip, no palate, they are able to feed almost like any other child. But when there is a palate involved, the sucking does not happen because of the escape of air through the palate and through the nose. Negative pressure is not sustained, and they have more difficulty. And such children, especially those with syndromes, may require assistance with special feeding bottles. The best among these that we know of is the Medela or the Haberman fetal bottle. The marketed name is the Medela. However, this is pretty expensive. There are much cheaper bottles which are squeezable, which are available in our country, and they cost just about 100 rupees, whereas a Medela costs thousands of rupees. Once we give them the feeding instructions, we follow them for the growth, for the increase in weight, and we use the WHO charts. The scores on the sides are the Z scores. Anything below -2 is very poor. We need to get it between 0 and -2 at least for optimal results during surgery and after. When we see the child, especially a wide unilateral cleft lip or a bilateral, any bilateral cleft lip child, we do send to our orthodontist for what is called pre-surgical orthodontics, and the common form used is the naso-alveolar molding. As the name is clear, there is alveolar molding using an acrylic plate, and there's a device which pushes the ala of the nose to get better shape of the nose and increase columella length. This certainly reduces, you can see before and after naso-alveolar molding, certainly reduces the extent of the clefting. The anterior-posterior disparity of the maxilla, the alveolar shelves, is also improved, and this helps us in easier repair, which we hope translates to a better result with the cleft lip. Here is a patient unilateral before NAM, after NAM, and after surgery. In a bilateral, this is much more important because, as we mentioned earlier, premaxilla is protruded and it might be rotated, and all this can be improved by NAM. As you can see in this patient, you can see the protrusion has improved, and here is a patient with a wide protruded, wide cleft protruded premaxilla after NAM. You can see on the lower side on the left, and after surgery, just after suture removal on the right side. In unilateral cleft lips, the problem is that the Cupid's bow is not clearly there in the patient, It is all there. It is like a jigsaw puzzle. We need to bring it in the right orientation. You can see that the point corresponding to the cleft Cupid's bow point on the non-cleft side is higher, and the lip is shorter at that level in a unilateral cleft lip. So the Millard's rotation advancement procedure, the rotation brings down the Cupid's bow. As you see, it is level with the counterpart on the other side. There is a gap under the columella that is filled by advancing tissue from the cleft side. That is the advancement. This is why it is called the rotation advancement procedure. And this is the most common procedure used today around the world. And at the same time, we also correct the deformities in the nose that happen, that are there in many of these patients. This is a pre and post-op of a partial cleft lip. Pre and post-op again. We operated 6 months at our center. This is 5 years after repair. Another patient, complete cleft. You can see the extent of the deformity of the nose in the primary, and this has been corrected, and no rhinoplasty has been done in this child. It's at 5 years after the lip repair. Another child, again you can see that the Cupid's bow is now well reconstructed, and the structures almost mimic the normal appearance. A partial bilateral cleft lip before and after surgery, and a complete bilateral cleft lip. You can see how protruded the premaxilla. This operation in this child was done before we had recourse to pre-surgical orthodontics, and still there is this much improvement in the appearance. This particular procedure was performed by Dr. Ednwala. You can see that there is a residual deformity in the nose. There is a broad tip. The columella is short. That needs to be corrected later. So here, after NAM, you can see that the preoperative appearance is improved, and then the surgery brings together the cleft edges, and we also do a muscle repair in the center to give good animation. Also here you can see the pleasant result after the primary repair. Cleft palate repair is performed primarily for good speech, and this is done around 1 year, 9 months to 1 year. And the usual techniques, the O-Waddle V2Y for partial, and the Pinto Waddle. Charles Pinto popularized the two long flap procedure in India. Worldwide, it is called the Bardak two long flap procedure. These days, in addition to this, other procedures like the furloughs, double opposing Z-plasty are also used. And here is a cleft palate before and after. You can see that the uvula, which was bifid, has been reconstructed. And then this has been done with a technique which has been developed by Dr. Ednwala. And you can see that there is a gap in the sides. Those heal within a very short time. If the lip is very widely cleft and there is a problem with tension, then we can borrow tissue from the insides of the cheek in the form of buccal flaps from one or both sides. Many of these children with such an approach have a good appearance of the lip. There may be a significant but slight blemish on the nose. We don't want these children to go to school with such a blemish and be ridiculed by their peers. So around 5.5 to 6 years, we do offer preschool rhinoplasty. And this is a child who had preschool rhinoplasty, and this is her 15 years later with no other procedure done on the nose or lip. This is another child with a preschool rhinoplasty. In a bilateral, as we mentioned, there are other problems in the nose that need correction, like the columella. This is a child 8 years after preschool rhinoplasty, and you can see that the appearance is almost like a normal child. When the alveolus is cleft in a complete cleft lip, then the eruption of the canine tooth may not be possible without good bone stock. So around 9 years, alveolar bone graft is done. The donor is usually the iliac crest. Here is a patient who has had alveolar bone graft. You can see the step in the alveolus. If this is not filled with bone, then the tooth bud will not erupt at the right place. It may be impacted or it may become ectopic. Speech is a very important aspect of the problems that a cleft palate child can have. From 3 years onwards. Regular assessment and therapy is done whenever indicated. We will show you what happens after good speech therapy. When there is nasality and velopharyngeal incompetence is suspected, this can be diagnosed by methods like nasoendoscopy, for which the patient should be cooperative. So we are only able to do it around 6 years at the earliest. And if there is significant VPI, then a surgery like a pharyngoplasty may be needed to correct that. Now here is a child who has not had any other operation apart from the palate repair. Now, this is a child where before speech therapy, even though it's in Malayalam, I think you can all understand that it's not clear. Now here is the same child after speech therapy. I hope that was clear, the effect of speech therapy. Now, the same thing on syllables. Not clear at all. And here, after speech therapy, so a good speech therapist works wonders on these children. Here, there is no velopharyngeal incompetence. The problem is articulatory problems, and these can be corrected by good speech therapy without any surgery. But if there were to be a gap in the velopharynx, which is not closing when it has to, then speech therapy will not be able to correct it completely. So then you need some surgery to correct it. And here is a child who had so you can see the facial grimace in this child also. This is after the operation. Speech becomes much clearer, and you can see that his morale also is much better, and there is no grimacing in this child. Orthodontics is very important in these children, and it starts soon after birth, and it goes up to the time when the growth is complete, like 16 to 18 years. Orthognathic surgery may be necessary for maxillary hypoplasia. Any surgery on the cleft lip or palate may be associated with some amount of maxillary hypoplasia, but in some patients, it is much more gross, like in this patient. And here, the maxilla has to be brought forward. Sometimes, if the advancement required is more than 1 centimeter, then the mandible is also set back. And here is a patient who has had a Le Fort osteotomy. The appearance is very good now, and all the scars are all inside. Nothing shows outside. But we try to avoid maxillary hypoplasia to the maximum. At the end of all this, if there are deformities in the nose, and if there is any deformity in the lip, we try and correct both of them together. Here is a patient who's had secondary rhinoplasty, Here is another who had a primary repair elsewhere with a septal deviation. You can see the correction there. Another patient 4 years after rhinoplasty. You can see the improvement in the appearance of the nose. Yet another. This is a 40+ patient, came to us with lip scar. There was a fistula on the lip, and you can see the nose, the septal deviation, alar problems that are seen there, and these have been improved by rhinoplasty and lip improvement at the same time. It's a bilateral patient. You can see the improvement in the columella and overall shape of the nose. Another bilateral came to us late, and you can see the improvement. This is a patient with oroocular cleft before and immediately after the stitches have been removed. Lateral cleft with a Z-plasty that has been done there to improve the appearance. And now to conclude, I will just show you the example of one 18-year-old patient who had a cleft lip repair done and a cleft palate repair done in 1991. At our center, fortunately, we don't have pictures of those. Had a bone graft done, and this is her after her orthodontics is complete. You can see the good alignment, and you can she had a rhinoplasty done for a blemish in the nose, septal deviation, and a small blemish in the lip. You can see the before and after pictures there. And this is her speech also. So that's the journey that a cleft child needs to take from birth till around 16, 18, maybe 20 years, sometimes longer than that if they have not had the treatment at the optimal time. I'm very pleased to say that now most of the patients come to us brought by their parents in time for their surgery, thanks to Smile Train, because now the awareness is so good that we don't get those patients who not had treatment in their childhood. They come at 30, 40 years for their palate and lip repairs. Thank you so much.
Thank you, sir. That has been a great, very nice, informative talk from you. You have the pictures and the photos were so much illustrative that some of them should be applied or strict to every obstetrician's office, because even today in some areas in rural areas, the patients afford for pregnancy termination for cleft lip and cleft palate. Still awareness is required here. Another thing I want to highlight, I want to comment something about the imaging part. Cleft lip and cleft palate can be diagnosed at around 13-14 weeks also with good imaging modalities, with good machines. But isolated cleft palate, yes, it is very difficult to diagnose because it is something what it is into the oropharynx. So one thing which I would like to suggest to all imaging people, that there is equal to sign of uvula. That is on the transverse view of this oropharynx. When there is fluid in oropharynx, you get two brachydonic bright lines that suggestive of that palate, the uvula. And when it is seen, that indirectly shows that the palate is, I mean, there is no cleft palate, it is intact. So it should be a routine part of your ultrasonography to each and every patient. And when it is not seen, when you are doubtful, then always go for a mid-sagittal view of the face, where slight neck extension with some fluid in oropharynx, you get direct visualization of the palate here. You can see directly with those. So when there is history, family history is there, one sibling is affected or parents are affected, then you have to look to these feta very, very carefully for this. And these are the tactics, some of the tactics to diagnose isolated cleft palate.
Thank you. Thank you so much.
So thank you, sir. Thank you. That has been a very nice and excellent part on your side. Now I would like Dr. Jaya to take over for next session.
Good evening, everyone. After this excellent deliberation, let us move to the another next session. which is on overview of cleft lip and cleft palate by our esteemed speaker, Dr. Ashish Jararia, sir. So, with great privilege, I would like to introduce him. He is currently Associate Professor OBGY at GMCH Nagpur. He has worked as unit in charge at Kama and Albis Hospital, JJ Group of Hospital, Mumbai. He has more than 20 publications in national and international journals. He's practicing critical care obstetrics since long. So I welcome you, sir, and invite you for your talk. Dr. Ashish, sir, are you there? Please, yeah.
Am I audible?
Yes, sir.
Great. So I was actually in OPD and I missed so many things. I was trying to see intermittently the proceedings, and I was so impressed by Narayan sir's lecture. I though couldn't hear it completely, but it was really an honor to be here. Should I go ahead with my presentation?
Yes, sir. Please.
Sir, it will be great, Narayan sir, if you could be there for my lecture so that I myself have many queries, so I can ask you at the end of my lecture. Thank you, Amox. Thank you, Maha Smiles, Cleft Care for Every Child. And thank you, Science Integra, for this opportunity. Thank you, Kiran Kurtoki sir and Bipin Pandit sir for this seminar. Extremely thankful to Sujit Kodkar sir, who is the convener. And thank you to Rashmi madam and Jaya Tulaskar madam for this opportunity. I acknowledge Dr. P. Narayan sir for his esteemed presence. Can I start my slideshow?
Yes.
Yeah.
If my screen is visible?
No, sir.
Not yet.
No.
Okay, let me share my screen. Yes, so the screen is there. Okay. Wait, where is this? Just a minute, just a minute. Is it visible now?
No, sir, not it.
Right, now I think now it should be visible. Yes. Is it visible now?
Yes, sir. Yes.
Yeah.
Sir.
Great. So Narayan sir has already told about cleft lip and cleft palate, and I'll be, as an OBGYN, I'll be just speaking about the problems of OBGYN and introduction to this cleft lip and cleft palate. Ideally, I should be speaking first, followed by Narayan sir. But anyways, I'll try to do my job. I'm Dr. Ashish Jararia. I'm Associate Professor at GMC Nagpur, and I'm also Vice President at Omega Hospital. Previously, Dr. Chaitanya sir was about to take this lecture, but then because he's overseas, I am doing this honor. I'm thankful to Dr. Jaya Tulaskar madam for the slides and the PPT. So we all know as an OBGYN that it is one of the most common congenital facial malformation, and it comes in isolation as well as it comes in combination. And as Narayanan sir says, the treatment at right age and right time with a multidisciplinary, interdisciplinary and coordinated care is the need. Now, what is this cleft lip and cleft palate? We know that failure of fusion of frontonasal and maxillary process is cleft lip, and failure of fusion of palatal shells of maxillary processes will lead rise to cleft palate. So,
sorry to disturb, Dr. Ashish, please make it full screen.
Great. Yes, sir. Yes, I'll do it. Okay. How to do it, sir?
Yeah, in the bottom line.
Slideshow.
That cup like.
Okay. Yes. I think now it's
it should do. Yeah,
yes.
right.
So we already know what is cleft lip and cleft palate. Now, why clefts are so predominant in facial lesion? We know that the heart develops very early and start pumping blood before the development of facial structures. And this development of cleft lip and palate is one of the most complicated process. So the cleft lip and the cleft palate is usually seen in the upper half. It is very rarely seen in the lower lip. And I really want to know from Narayanan sir later on why it occurs. But as we know, the logic says as the upper lip and the upper palate develops from three things, the frontonasal process and the maxillary processes. So these three things makes this upper palate. This is to diagrammatically represent what is this primary palate and secondary palate. So, and how this palate and the upper lip develops. I think this is this. So the development of palate begins and gets completed around 12 weeks. In the median nasal prominence fuse in the midline to form primary palate. The medial side of maxillary process rotate and develop into lateral palating process, and it fuse in the midline to form secondary palate. So failure of midline fusion leads to cleft palate. So this is the embryological aspect of cleft lip and cleft palate. As a OBGYN, we usually do 2 ultrasounds, one at 6 to 8 weeks for viability. And many times, few of the OBGYN also do NT scan at 11 to 14 weeks. So this cleft lip and cleft palate usually does not affect us much because we really actually depends on the anomaly scan to radiologists or the fetal medicine experts to give us a ready-made diagnosis of cleft lip and cleft palate. So we really don't bother much about these anatomical things, but we must know that cleft palate can come as surprises, especially the soft tissue part of the palate, which is very difficult to visualize on ultrasound. Many times the radiologists, expert radiologists can also miss it. So just to know the etiology of cleft lip and cleft palate, already sir has described it in great detail. But there is definite genetic predisposition, some nutritional factors, the stress is all related to it. Then certain drugs like amanitin, cortisone, thalidomide, anti-cancer drugs are responsible for it. And definitely the alcohol and smoking, which we OBGYN are really worried about. Radiation and infection can also is responsible for this cleft lip and cleft palate. So we must remember that there is something called a syndromic cleft lip and cleft palate. There are various syndromes associated with cleft lip and cleft palate, and we must be with our pediatrician, neonatologist help, we must rule out this if they are there. So autosomal dominant disease like Van der Waals syndrome, EEC, autosomal recessive diseases like Meckel syndrome, orofacial digital syndrome type 2, and Robert syndrome, and X-linked disorders like orofacial digital syndrome and isolated cleft palate with uncli glossia. Chromosomal diseases in 13 and 18, we may have trisomy 13 and 18, we may have cleft lip, cleft palate along with other things. Non-Mendelian syndromes like Pierre-Robin and clefting with congenital heart disease should also be considered as an OBGYN. Now, coming to isolated cleft lip or isolated cleft palate. About isolated cleft palate, there is a strong genetic influence. It is more common in females, and severity may range from mild notching of tip of ular to cleft ascending soft palate alone or into secondary hard palate up to incisive foramen. It is usually associated with Pierre-Robin syndrome. Now, what are the other factors that influence the incidence of cleft lip and cleft palate? We know that cleft lip, cleft palate is in combination is responsible for 45% of total these disorders. Isolated cleft lip is very rare, it's just there in 15% cases, and isolated palate in 40% of the total cases. Sex is more common in males than females. Overall, when we talk of total incidence of cleft lip and cleft palate, American Indians and Afghans shows a higher incidence when you think of race. Babies with isolated cleft palate have lower birth weight than those with isolated cleft lip. Increasing incidence has been reported with increasing parental age. Incidence is more in the firstborn child, and malnutrition increases the chances of cleft lip and cleft palate. So all these factors impacting the incidence we must think of. This is a picture depicting types of cleft lip and palates. We know this normal anatomy: the lip, the hard palate, the soft palate, which is hanging like umbrella from the hard palate, and a uvula, which is where this soft palate unites. If there is a unilateral cleft lip, it will look like this. Then you have a bilateral cleft lip, you had a cleft uvula, you had a unilateral cleft palate, you may have a bilateral cleft palate, you have a unilateral cleft lip and anterior palate, you have a unilateral cleft lip and full palate, and a bilateral cleft lip and anterior palate, or you may have it bilateral cleft lip and full palate. So, sir has already described it and the surgeries has already explained. Now, coming to the ultrasonography of this diagnosis, the equal sign is a novel marker in the diagnosis of fetal isolated cleft palate. And normally, okay, so this is the two ultrasound pictures which OBGYN may be interested in. So on the right hand side, you have a sagittal plane. When we do an NT scan for doing the nasal bone thickness, we do this this scan. This view will tell you about this physiological equal sign. So if there is a normal, palate, there's a normal soft palate, you will see this equal, and inability to see this equal sign. It may be there is maybe a possibility of cleft palate. Now this is another picture of a retronasal triangle. This is how we see. This is how the retronasal triangle is seen, and we can see again the equal sign here. So these two views, the retronasal triangle view and the sagittal plane in NT scan, will help you in making a diagnosis. Clinical features, we know that there are feeding problems in neonates born with cleft lip and cleft palate. There's failure to thrive, there's speech problems, the hearing problems, the dental problems, and psychological problems along with it. Now, the multidisciplinary approach is required, and we can put in pediatrician or an OBGYN here in the center. So we need to have a orthodontist, a cleft surgeon, a speech and ENT specialist, oral and maxillofacial surgeon, prosthodontist, and a plastic surgeon in your team, along with pediatrician, clinical psychologist, and specialist nurse, clinical geneticist, and if possible, pedodontist and ENT surgeon. So these are so many multidisciplinary approaches need, and initial management as a OBGYN, we all know special nipples are there, the bottle feeders are there, and we use of feeding obturator and special feeders we use in our common practice day in and day out. The rule of 10 is something which we must remember. Lip correction should be done as early as possible. 10 weeks age with 10 pounds body weight with 10 gram hemoglobin. A soft palate correction can be done between 18 to 24 months, and hard palate correction should be done by the age of 4 to 5 years. So, education, counseling, treatment at right age and right time, and psychological rehabilitation is the need of the hour as far as the OBGYN perspective in cleft lip, cleft palate management is concerned. I think this is all about from my side as an OBGYN, and thank you, Sujit sir, once again, and Jaya ma'am for this opportunity. And I request Narayanan sir to please give some inputs to us from OBGYN perspective. Thank you.
Yeah, Dr. Ashish, that has been very nice and a basic talk. The basic things which one should know, every obstetrician should know, that has been covered in your talk. I expect Dr. Narayan sir to answer some questions from Dr. Ashish himself.
Sure.
Yeah, because he at the start of talk, he already told that he's going to ask some questions basically to clear
Right.
as an obstetrician. Just for imaging part, I already told that this equal to sign of uvula at the level of oropharynx is a screening test.
Right.
Definitive test is at the mid-sagittal level of the oropharynx, having with some slight extended, hyperextended neck with some fluid node. That will give the definitive diagnosis of cleft palate, whether normal cleft is there or not.
Right. I think I learned something from about that equal sign today. I think, and that pictures that Dr. Ashish showed were very nice. There's just one thing that I would like to point out about this rule of tens. We've all learned this from our MBBS days about the rule of tens, but nowadays very few of us practice that, because especially in our countries, developing countries especially, in 10 weeks, that is 2.5 months, very few children attain that weight of 10 pounds. So it's like more often 3 to 6 months that we get our children to come to 5.5 to 6 kilos. So the rule of tens, that way is the weight is right, but the time that they attain that weight is not the same in all countries. So this might be okay for the Western nations, but we don't follow that now. It's like even Smile Train, the guidelines are 3 to 6 months, not before 3 months. And the weight or weight should be at least around 5 kilos at the time of the lip repair. So that one thing I would like to mention. And about the feeding also, the plates are not so often used. Of course, when NAM is done and an acrylic plate is placed, that does help. But otherwise, generally, other feeding practices like these special bottles or even the traditional palada, which is the conch-shaped structure, those things do help in the feeding. And when the plates are placed there with a constant abrasion on the palate, the tissues are not the same consistency. So many of us don't like the plates to be used here.
Sir, I have one more question for you.
Yes, please. Yes.
As a OBGYN, we need to report many things to the NMC. Like we have to report MTPs, we have to report births, we have to report deaths as in hospital.
Yes.
But then we also have to report these birth defects.
Right.
It is mandatory from our side as I work in government. We regularly report these birth defects to NMC. But I don't know how many of private hospitals are really reporting birth defects to NMC. And the one more point which I want to mention is, as a OBGYN, we really concentrate on those major defects, which either requires termination or which are really not compatible with life. So these are the two main birth defects which we really work on, or we really concentrate on. And many times these smaller defects, they like this talipes equinovarus or cleft lip and cleft palate, are many times they are neglected, you can say. So what is your say in that? Like what is the need of our?
Very true. What you said is very true about reporting. Sometime back, with the Association of Plastic Surgeons, Dr. Sridhar, he took it up with the government. Then at that time, he started with the Tamil Nadu government to make it compulsory to report all clefts, because there is no registry. All the statistics you get in India are all estimates. There is no definite reporting of all the clefts from all centers, even from government centers, even from primary health centers. It doesn't happen. So that does need to come in. The Plastic Surgery Association at least and the Cleft Society has been taking it up, and hopefully it will become more universal in the coming years. So that is necessary, because especially in the rural areas, it may get completely neglected. But thankfully, Smile Train has centers spread out all over the country, even in the areas which are not previously manned by cleft surgeons. So that now awareness is coming in those places also. Very thankfully, I am from Kerala, where the awareness is very high. So even if there's a small blemish, just a microform, just a small break there, they will come and ask us for correction of those. But I'm sure it's not the case. I have worked in other states. I'm sure the case is not the same everywhere. It needs to be, the government needs to bring up the awareness. Smile Train, for its part, is spreading the awareness through all means, social media, through having cleft cons, etc. So that is definitely there. Sorry, the second question that you asked was on?
Yes, what needs to be done more on this birth registry? That was one. And then I must congratulate Sujit sir and Jaya ma'am for having this CME in Amox, because we as Amoxian also needs to really be aware and
Hello?
He has lost
Hello?
connection.
Yes, we've lost you, unfortunately.
Actually, I am practicing in Wardha district. It is a small district place in Maharashtra. Every end of the month, we have to send the data. That is HMIS, Hospital Information System. So there is a long column on birth defects. So
I see.
Yeah, so we have to send it by that way also, online data at the end of the month. Yeah.
Okay.
Ashish sir, are you there? You were saying something?
No, he's not there still.
Okay.
So this goes to NMC, is it?
Yeah,
yes. Corporation.
Yeah, sorry. So about the defects, the major defects is that does get prime importance, but the clefts, though they may not be, they are not life-threatening, they can be devastating to the parents, and they do require timely treatment, especially if we are going to do NAM, if you're going to do pre-surgical orthodontics, we need to get the patients in the first few weeks, because this depends on the maternal hormones. They cause moldability of the lip and the nose. That is why we are able to get that in better alignment. But if we lose that early period, they come to us, say 2-3 months or 4 months later, we cannot do the NAM. Of course, we can still do the surgery, but it's going to be more difficult. Probably the results may be not as good. Though the long-term results of all this pre-surgical orthodontics has not yet been known. There are many reports that it's not constant. It's okay for the time of the surgery, little after, but then later on it still goes back to where it was. So that is there, but certainly it does help during the surgery, and especially in a bilateral, it helps a lot. So for that, we need timely intervention for a cleft lip patient. For a cleft palate, definitely the surgery needs to be done at least 9 months to 1 year, because there later on the wrong patterns get imprinted in the brain, and then to get it corrected from there is much more difficult, even with good surgery. So that is why for the palate especially, even if there is a late presentation, then we would go in and do the palate first and do the lip later. There are centers like Pondicherry where the awareness has not been as well as good as in places like Kerala, where Dr. Karun Agarwal actually changed the protocol completely. He would always operate only on the palate first. At around 9 months to 1 year, he would operate on the palate and then ask them to come back for the lip. Because the blemish was still there, the parents would bring the child. Whereas if the lip was done and the palate only was there, these people would say, okay, it's all inside. we can't afford to lose that much time from our work, and we'll see about that later. They would bring that child, if it's a girl, towards close to marriage age and say the child is not getting married, and it's much more difficult to get optimal speech at that time. So I think the only way this can be corrected is by spreading the word, awareness, and government should do more on this, but certainly organizations like Smile Train are doing quite a lot. When I started here 26 years ago, every month we would see at least one adult cleft lip or palate. Today in a year we see maybe one or maximum. And I think that credit goes to organizations like Smile Train mostly, because they have centers now spread all over the states in different parts of the country.
Thank you so much for giving us so much knowledge. Now, I would like to extend vote of thanks. So, I would like to thank our AMOX President, Dr. Kiran Kurtoti sir, respected Dr. Rajendra Singh Pardesi sir for blessing this webinar. Then Renu Mehta madam from Smile Train. I would like to thank our respected speakers, Dr. Narayanan sir and Dr. Ashish Zararia sir for their excellent deliberations and their valuable inputs. I would also like to thank Dr. Rashmikar madam, Dr. Sujit Konkar sir, and Rohan and Science Integra team for this technical assistance, without which it was not possible for us to telecast this webinar. Thank you all of you.
Thank you so much. Wonderful experience. Thank you.
Thank you, sir.
Thank you.
Thank you, ma'am. Thank you, Sujit.